So this session belongs to Alumni Desk, and we have speakers from all the alumni, I hope. Most of them are the alumni of GMCH. So first we have a keynote address by Dr. Vishali Gupta. All of us are well aware about Dr. Vishali Gupta. She is a professor at Advanced Eye Center and taking care of uvea as well as vitreoretina. So she is going to talk about imaging biomarkers in infective uveitis. Dr. Vishali, please.
Thank you, sir, for the kind introduction. So the topic is imaging biomarkers in uveitis. I'm just going to show a couple of cases, how to look for the biomarkers and how not to avoid any mistakes while making the diagnosis. Now, first important thing when we talk of the imaging is not to look at only fancy images. It is also to look at the basic, humble clinical photograph which is equivalent of clinical examination. So I'll give you an example. Here is a 42-year-old super VIP being treated as intermediate uveitis in New Delhi, no response to steroids, has been to multiple centers. He has been given immunosuppressive therapy for 2 years and he did not respond. So the plan was to shift to anti-TNF, which is the biologics. So this is how he comes to us. Left eye, intermediate uveitis, refractory to therapy. So the fluorescein angiography was done. Fluorescein angiogram, if you see, it showed diffuse leakage from the capillaries all over and cystoid macular edema, not responding to steroids and methotrexate 2 years. All the tests for infection are negative. We did the OCT which showed macular edema. So the normal instinct would be, okay, there is uveitic macular edema, inject steroid, inject something into the eye. But what was being missed? What was being missed was a thorough clinical exam. And if you look at this picture carefully, these arrowheads, there were kind of little cilia-like structures lying in the eye. Now, why should these be there in a patient with intermediate uveitis? So we took the history and he said, well, 2 years ago, I was driving a bike and caterpillar hair went into my eye. Few of them were removed. But following that, I continued to have decreased vision and multiple episodes. And when I went to the doctor, they diagnosed it as intermediate uveitis. They gave me steroids, and then he went from one tertiary center to other because it was diagnosed as intermediate uveitis. Somebody gave methotrexate, then MMF was added, and finally what was done for him was doing the vitrectomy. You can see here the caterpillar hair. There were 2 of them which were removed from the eye. All the treatment was stopped, and now I have almost 4 or 5 years follow-up with him. You know, the patient is doing fine. So the first important thing is the clinical exam, and there is no substitute for a good clinical exam other than this. So the take home you should have from this case is that detailed clinical exam, history and general physical exam before you even actually order imaging on labs. And corollary to this is a patient with Fuchs uveitis actually. The Fuchs uveitis patients would always have vitreous floaters. So vitreous opacities are a part of Fuchs. Please do not confuse it with intermediate uveitis because I see almost 1 to 2 patients every day where Fuchs patients unfortunately are receiving immunosuppression because we believe in the old definition of Fuchs, which is cataract, heterochromia, and stellate capies. We do not think I mean, what if Fuchs did not notice vitreous floaters? People after him noticed it. So don't go by the definitions which are century old and start treating them with steroids and immunosuppressive. The second thing is multimodal imaging is the buzzword. Everybody loves MMI, it's become kind of, nobody understands it if you ask me, but everybody talks about it. So MMI composes of 6-7 imaging modalities and you have to combine them. But the problem is, as a younger colleague, you guys don't know which investigation or which imaging modality to do and for what. So I'll show you an example. Now this is the 29-year-old case of scotoma. Color photo is done, which is a pseudo color imaging. This is called multicolor imaging, which is available on Heidelberg. And most of the institutes now, those they have Heidelberg, they do not have true color picture. And when you start sending for opinion on WhatsApp, you may end up showing this picture to your colleague. Well, there is something, what do I do? If you ask me, I think this photo looks normal. Though I have circled the area of interest, still I can't see much. But when you move on to the conventional, you see this is the true color photo, which shows a granuloma sitting out there. So you have to be very careful what you are ordering, because what you are ordering may not be the right investigation. Like what is right for retina may not be right for uveitis. And to give you another example, if I show you MCI, which is multicolor imaging, everything seems healed to me. I will not treat that patient unless I go to true color picture, which shows beautifully these arrows indicating that the edge of choroiditis is active and center is healing. So we did publish this, that retinochoroidal lesions in posterior uveitis may be very poorly identified on multicolor imaging compared with true color picture or clinical examination. So one must exercise caution in connecting to the disease morphology based on color picture, multicolor images alone. So that is why you have to be very guarded when you start giving advices on WhatsApp based on some imaging modality somewhere, because unless and until you have seen the patient, you do not or you should not trust the imaging, enough to give your opinion. The third thing, which is that sometimes we get the imaging done, but we don't study the meaning of the imaging. So choosing, and then we order the lab investigations, and the lab investigations come positive, and then we treat, and we complicate the whole thing unnecessarily. This is the patient actually managed in this very city. She's a young girl. She was diagnosed as TB choroiditis. She received anti-TB drugs and steroids, and then she was not responding for almost, I think, 3 months, and that is how she came to me. Now look at this. What is this kind of a structure here? It's linear, isn't it? It's linear. So if you have read your anatomy of choroid anatomy is what? It's lobules, isn't it? Choroid is not linear. So if the choroid will get inflamed, if the individual lobules are inflamed, you will get focal choroiditis. If they coalesce together, you will get diffuse. Why the hell you will get a linear choroiditis like this? So it is not choroiditis. Somebody made 2-3 mistakes. The first mistake they made is labeling it as choroiditis, while to me, even a nursery child should be able to say this is not choroiditis because it doesn't fit into the anatomy. And the second mistake they made was ordering the investigations without realizing that it was not even choroiditis. So they order the investigations, TB comes positive, and then they start anti-TB treatment. And since they believe that anti-TB has to be combined with steroids, they give steroids also. So I asked patients to show me the first photographs which were taken. Now this is the first photograph. This is the review of the images which the first person has taken. Now look at this. This is subretinal deposit. This is neither retinitis nor choroiditis because it is going in a linear fashion, and this is the left eye. And if you look at the angiogram, these are multiple hyperfluorescent which are becoming more hyperfluorescent. Retinitis and choroiditis are hypo to hyper. They do not become hyper to hyper, which means this was not the correct. So it was actually a case with fibrinous CSC, which got complicated because of the treatment with steroids. We stopped everything, and that's how the thing ended. So the mistake number 4, which is not truly related to imaging, but is that based on the imaging, like I said, we order. Why would I order TB test for each and every patient when the patient does not even require the test? So what is important? Important is that before you order any test, and now I have started applying it to my imaging also, you need to know something called pre-test probability. What is pre-test probability? Pre-test probability is that I am ordering this test. What is the probability that in a given situation this test will come positive? If the probability is high, only then that test has a value. For example, you are seeing acute anterior uveitis in a young adult, which is fibrinous non-granulomatous. Now that to you is straightforward HLA-B27. So what is the pre-test probability that your diagnosis is TB? Very low. So please do not order TB test for him, because if your pre-test probability is low, I will not go into post-test probabilities, but the likelihood of the diagnosis being made is wrong. So pre-test probability affects the probability that a positive or the negative test will occur. Higher the probability, more likely is to get the positive test and more likely you will treat. I'll show you an example of this girl, a young girl from actually AIIMS New Delhi, working in a mycobacterium lab, shows up, presents with a picture like this, Now, she is the one where you have serpiginous like choroiditis, you have a scenario of exposure to TB, so when you look at it, you say it could be TB serpiginous choroiditis because that is the first differential that comes to your mind. So the test probability of TB is very high. So you get the test done. However, she went to all the major centers in the country. She was diagnosed as macular serpiginous choroiditis, treated with one immunosuppression after the other, and this is how she ended up with a large granuloma compromising her central vision. And finally, when we looked for the cause very desperately, and we found what they had reported in the parotid as Warthin's tumor was actually TB of the parotid gland. So why did I chase? Her Montius was negative, her IGRA was negative, but I was so convinced this was TB, so I kept on trying to find a course, and that is how we ended up. So look at the attention at the pretest probability. I will take this last one, fifth is that many a times you order the imaging, but you don't look at the imaging and you make mistakes. I will show you an example of this child, not child, young adult, 23-year-old male. He's admitted in our pediatric ward for his IgG4 related disease. And he says since last 2 days there is a sudden loss of vision. So I look at it, and there is something happening here. His vision is counting finger and the other eye is affected as well. Now what is it? Anybody? So what is the first image you should order? You look at it. It's not straightforward retinitis. It is neither straightforward choroiditis. So there is something happening at the level of RPE. So when you think of RPE, you get autofluorescence. Now autofluorescence shows these linear tracks, you know. So what you cannot have these linear lesions either in retinitis or in choroiditis. So we do OCT through this, which again shows there are these column-like tracks. Look at these. These are very, very classic of laser-induced injury with all those laser toys and laser markers going around in the market. This is a very, very typically for laser. We did everything, fluorescein, angiography, because we were so psyched by that IgG4 disease that we thought it could be inflammatory, but it was not inflammatory. So when I asked the pediatrician that has he been exposed to laser, pediatrician thought we were mad because he said it's IgG4 disease. And finally the boy said, oh, this is the laser. I had visited Goa 3 months ago and I had purchased it from there. And last week before coming to the hospital, I went to hostel to collect my sister. And while she was coming, I was shining this in the side mirror of the car and looking at it. So in the process, he had burnt his fovea of both the eyes. It was not uveitis, it did not require, and the clue came from multifocal imaging. So it's very important. We've published this, but that's besides the point. But the take-home message is, if the disease phenotype does not align with the systemic disease, consider the probability of coexisting modalities. So I have actually 10 mistakes, which I will not. First 5 I have shown you, 5 some other time. But the thing is that this is my last slide, which is my favorite slide. When you are dead, you don't know you are dead. The pain is felt by others. Similarly, when you make mistakes, you probably don't realize you are making mistakes. The pain will be felt by the patient and the attendants, and it's important to keep up to date. And besides being up to date, the skills. Don't get captivated by, people showing you OCT angios and all. That's all nonsense if you ask me. Don't get influenced by the technology. I show all that because that is a different forum. But the technology does not mean that you lose your basics. If you have your basics intact, 70% of the time you will be able to manage, and the rest 30% can be referred to higher center. It doesn't have to be for you to wait for all the technologies to manage 100%. And I love this new word called hyposkelia. Hyposkelia is like when you don't have the skills and you just find excuses that I don't have technology, so I'm not able to do it. So learn your anatomy, learn your physiology, learn your basic skills. There is no substitute for this. And believe me, I'm saying it because I have tried all the technologies, and we also show in different meetings, OCT, guided surgeries and all, but your clinical skills have to be developed. Thank you very much for your patience here.